Mission is simple: to help high achievers naturally eliminate emotional and physical obstacles so they can optimize their life for higher achievement. Welcome. You have just entered the Genesis Zone. Good day, and welcome to the Genesis Zone show. This is Dr. Brian Brown. Thank you for joining us on this busy Thursday and just taking time out of your schedule. I don't take that for granted. Do you have a moody brain? That's the question for today. Have you ever been prescribed an antidepressant but felt like it was overkill? If so, then this episode is for you. So stay tuned as we discuss the concept of a moody brain and what you can do about it. I think it's really important in this day and age to be talking about mood and all aspects of brain health as it relates to mood. So what is a moody brain? Well, in a previous episode in April, I talked about, I introduced this concept of moody brain. So you can go back and listen to that episode for more detail on, my understanding as I've come to know it of what a moody brain is. But just for review, I've spoken to several people about this term since I first aired that episode about the moody brain in April. Interestingly, people have told me that they can really relate to the term moody brain. They'll say things like, yes, that's me. I can totally relate to that. And when I asked for more specifics, like what really resonated with you, and they said like everything. Like I have a moody brain. I totally get it. I understand it now. So having practiced psychiatry for almost 25 years now, I've worked with clients in my professional life who have undoubtedly had moody brains. And I have to be completely honest and transparent. Personally, I've struggled with a moody brain in the past myself. In fact, I've dealt with moody brain in the worst sense for 16 years. I tried 9 different, antidepressant medications, and none of them ever worked. They seemed to make things worse. So it was just this constant hamster wheel of being involved with medications for the treatment of my moody brain. So what is a moody brain? Well, a moody brain, first of all, if you understand this, can occur on a spectrum. So just draw a straight line horizontally on your paper. On one end of that line is the mild end of the spectrum, meaning milder symptoms of moody brain. And I'm going to get into the symptoms here in just a moment, so hang tight. But on one end is this mild moody brain, and on the other end is the more severe moody brain symptoms and issues. And in the middle is the more moderate type moody brain symptoms. Now, not every time, but in most cases, if your moody brain is on the severe end of the spectrum, you've at least been offered antidepressant or anti-anxiety medications. And if I'm being completely honest, there's a good chance you're on psychiatric medications right now, or you've tried to come off of those medications with great difficulty. And maybe you were successful in coming off of them, but it was miserable in that process. Sadly, it's not just the people on the severe end of the scale that end up on medications. Many people who are on the mild end of the scale, or even the moderate end, in the middle, are on psychiatric medications as well. There's a lot of reasons why that happens. I discussed that in that first episode back in April. But this is why it's sad to me that no matter where you are on the spectrum, you've probably been offered an antidepressant, and there's a good chance that you're on an antidepressant or anti-anxiety medications. In psychiatric training, they teach us that there are 2 primary fundamentals when it comes to prescribing medications, but many times these fundamentals are largely ignored. And I think it has to do with the pressures of clinical practice today, where reimbursement from insurance companies has gone down so low that you have to work off of a volume model. So you're seeing 4 to 6 patients an hour. That means you don't have time to spend with them to tease through the nuances of what's going on. And that's a problem. So that's why these fundamentals get ignored. They take time to tease out. So fundamental number 1 is all psychiatric conditions have a medical cause until proven otherwise. And fundamental number 2, if a person is on a psychiatric medication, they must periodically be challenged to come off of those medications. Now, I'll have to be totally honest with you. When you are in your training, you have the luxury of time. You may be assigned 1 or 2 clients when you're first beginning, and you're able to follow these fundamentals to a T. And you do that for most of your training in this particular respect. And then when you get out into the real world and you start actually practicing, the reality slaps you in the face and you realize, oh my God, I can't follow fundamental number 1 and fundamental number 2 because I don't have time to do that. And then it becomes path of least resistance at that point. I've got to do what I've got to do to survive the day, to make it through the day. I'm trying to give you a little bit of insight into a clinician's brain, because I've worked in large practices where there were 20 of us clinicians practicing. I've worked in solo practice where it's just me or another person practicing with me. So the mindset becomes similar. And it's one of those things that caused me to come out of traditional psychiatry, because it was like, this is not what I signed up for. I signed up to help people. And if you follow fundamental number 1 and fundamental number 2, understanding that there's probably a medical cause for this psychiatric condition until proven otherwise. And then those that are on medication, try to help them get off of them periodically. If you follow those 2 fundamentals, it's very fulfilling in your clinical practice. If you don't, it becomes very mundane and you get really burnt out quickly. So anyway, once you get into clinical practice, you're no longer able to do what you were able to do in your training because you just simply don't have the time. So with the cost of depression in the United States alone hovering around $326 billion annually, according to the most recent numbers in 2020, and anxiety and poorly managed stress costing Americans about $300 billion. And then you add to that fatigue and low energy costing the US economy about $400 billion annually. And then brain fog, lack of focus, and distractibility costing the US economy about $391 billion. Then the total burden to the US economy alone is about $1.4 trillion. That's larger than the GDP of most countries throughout the world, significantly larger. So we are spending a lot of money on mental health care. We're spending a lot of money on moody brain because guess what? These things that I just talked to you about, whether they be, depression or anxiety or low energy or brain fog or lack of focus or distractibility that make up that 1.4 trillion, those are the things that are involved in moody brain, or in a moody brain. Allow me to explain really quickly. In all my years of clinical practice, I have learned that you can distill the moody brain phenomena into 5 distinct types. Number 1 is the sad type. This is the person that really struggles with depressive-like symptoms. Now, hear me when I say this. This is critically important. If you don't hear anything else, just because you have depressive symptoms doesn't mean you have a depressive disorder, a diagnosable condition. Depressive symptoms don't make make you have a diagnosis. Here's what ends up happening. In order to get insurance reimbursement, there has to be a diagnosis there. In order to justify a medication, there has to be a diagnosis there. So you end up by default with a major depressive diagnosis, or in some lesser cases, a depression not otherwise specified, meaning it's kind of in limbo, but still there are firm diagnoses that insurance companies will rate you on when they get ready to give you a health insurance policy or a life insurance policy. It'll count against you. And you end up with these diagnoses simply because the health professional had no other choice. If they wanted to get reimbursed, if they wanted to prescribe the medication, they had to have a diagnosis there. So what I'm trying to say is there are a lot of people that fall into the sad type of moody brain category that don't really have official psychiatric diagnoses. They're given psychiatric diagnoses, but they don't really meet the criteria. I saw this over and over and over again in clinical practice, where I would be referred a client from, say, an OBGYN in town. So could you look at Miss So-and-so? She's struggling with depression. I would get her in, and they would say, we've tried like 3 different antidepressants. We can't get any headway. She would come to me, and I would take a very thorough history, and I would realize, wait a minute, this person doesn't have a clinical diagnosis of depression. That's the problem. They have some depressive symptoms, but they also have some stress-related anxiety symptoms. They also have low energy. They also have this scattered thinking. And yes, you could say, okay, Brian, that's all related to depression. And most psychiatrists would argue that, yes, that's related to depression, but not necessarily. Because remember, fundamental number 1 said it's medical until proven otherwise. In other words, we've got to look for underlying root causes before we proceed forward and prescribe a medication. But here's how this plays out. You go in for a psychiatric visit, and your initial visit, in some clinics, it's a little bit of time. It's 30 to 45 minutes. In some clinics, it's an hour, hour and a half. Those are the better clinics. But still, in an hour and a half time, let's just say you had the most time you could be given for an initial psychiatric evaluation. Chances are you're going to come out of there with a prescription for at least 1 medication, sometimes 2 or 3. And the reason is, I'm trying to help you understand the thinking of a broken system, this medical system that we work in. The problem is that we're prescribing medications to people who just have symptoms. They don't have clinical disorders. Now, how this differs from, say, studies that are used to get these medications approved, when people come into these studies, they have to go through stringent testing to prove that they have a clinically diagnosable psychiatric disorder. So these studies are very pure. But in clinical practice, it's not pure at all. There's a lot of gray area, and the gray area comes in when we're making decisions about people based only on their symptoms and calling it something that, and a lot of times it's not. Now, I know I'm coming across a little bit negative against the current medical system. I don't want to come across that way at all, because there are clinicians who are very good at what they do. They're top notch. They'll call a spade, and they'll say, this person doesn't have a diagnosable depressive disorder. We're not quite sure what it is yet, but we know it's not a diagnosable depressive disorder, and we're going to find out what it is. And those are the clinicians that really pour their heart and soul, not that other people don't, but they pour their heart and soul into their clients to really figure out what's going on. And I'm not trying to say that there's no place for medications. There's a perfect place for medications. I'll discuss that here in just a moment. The other type of moody brain is the stress type. And we run into the same issue with the stressed type as we do with any other person that's struggling with stress issues or anxiety issues. Just because they have poor stress management type issues, or they have anxiety type issues, doesn't mean they have a diagnosable psychiatric anxiety condition. It's the same thing as the sad type. And then we have the sluggish type, this low energy type. This is probably one of the most frustrating types, not just for psychiatric mental health professionals, but for medical professionals in general, because one of the largest complaints, by and large, that you have people come in to a clinic and say that's going on with them, they say, I have low energy. And the practitioner, medical provider scratches their head. They order some lab work. They take a history, they order some lab work. The lab work comes back, and all the lab work is quote unquote normal, meaning it falls within those normal parameters that are on the right-hand side of the laboratory page. But is it optimal? That's the question. And that's where we run into problems when it comes to treating sluggishness or low energy, or this low energy brain. And then there's this fourth type called the scattered type. I don't know any other way to put it other than these people are just kind of scattered. Their attention concentration and focus is off. They're kind of all over the place. In psychiatric terms and primary care terms, they might be mislabeled as ADHD, adult ADHD. And it boggles my mind because to make a firm diagnosis of attention deficit disorder or attention deficit hyperactivity disorder, and then you specify the type it is, inattentive type or hyperactive type, regardless, when it frustrates me when I have a 52-year-old that comes in and they've just been put on a stimulant medication like Adderall or Vyvanse or Concerta or Ritalin. And I'm like, when did you start having symptoms with attention, concentration, and focus? Oh, that's been going on for about 3 years now. Well, I mean, did somebody diagnose you with ADHD? Oh yeah, they gave me a diagnosis of ADHD. They said I had it, hands down. And I start taking a history and I'm like, tell me what school career was like for you in, say, high school. And they said, oh, I didn't have any problems then. Well, what was it like in middle school? Oh, I didn't have any problems then. What was it like in elementary school? I didn't have any problems then. Well, guess what? In order to have an ADHD diagnosis, you've got to have issues that date back to those early elementary school age years. And a large part of people who fall into this scattered, moody brain type get misdiagnosed with ADHD. They get put on stimulant medications. Then they wonder why they're having agitation and irritability. They wonder why they can't sleep. They wonder why they're jittery and nervous all the time, anxious. They wonder why they're having heart palpitations. It's because they're on an amphetamine and they have no business being on an amphetamine. So, and the last type, the fifth type, is just kind of a conglomerate of the sad type, the stress type, the sluggish type, the scattered type. And then there's also in that category, the sleepless type, the sickly type, meaning they're having trouble sleeping. And the sickly type has autoimmune type condition going on. And then there's the person that struggles with weight. Yes, weight issues can affect brain health and vice versa. So there's that fifth type is what I call 7-layer salad, because there's 7 different categories within there that they have a little bit of each of those. And it's very common to see clients like that. And that one, you want to talk about really confusing a health professional on the front line of care. Have a person come in that's struggling with sadness, struggling with stress management. They're struggling with low energy. They're struggling with being scatterbrained. They're struggling with being having sleep issues. They're struggling with autoimmune issues. They're struggling with weight issues. That clinician who has literally 10 to 15 minutes to see that person, that's including their documentation. What do you do with that person? I mean, they don't know. So living with a moody brain is not fun. It's not fun for clinicians. It's not fun for the clients, the patients. It's not fun at all, because patients by and large end up in limbo and they don't really have anywhere to go. They don't have anyone that will actually listen to them. They don't have anyone that will hone in and say, okay, we're going to roll up our sleeves and we're going to figure this thing out. But the golden question is this: if you have a moody brain, and it doesn't matter which of the 5 types you are, do you really need prescription medications to deal with it? Well, another question is, what other strategies can help resolve the moody brain issues? Well, let's talk about medications really quickly. Medications, as I said, I know it seems like I bash medications. I don't. Yeah, I had 16 years with 9 different medications. They didn't work for me. They had a lot of side effects. I mean, a lot of side effects, and they're not good side effects. So you have to take that into consideration when you're prescribing medications, and you have to be honest with your clients and saying, listen, these list of things could happen when you're taking this medication. Here's the ones that are the most likely. Here are the ones that are least likely. Medications have their place. And what place do medications have? I firmly believe if a person is suicidal or homicidal, they're in the inpatient psychiatric unit and they need to be stabilized, we need to get them stabilized on a medication. We need to discharge them into the community on those medications with strict follow-up so that we make sure that they're on the right path and they're continuing to do well, which is standard protocol, by the way, for somebody that's had that happen. And then And then after, if this is the first time they're on medications, in about 9 to 12 months, we need to challenge, which is fundamental number 2. We need to challenge lowering their dose, see if they can tolerate a lower dose. But here's what happens. Clinicians get scared. They say, oh God, 9 months ago, this person was in the inpatient unit. They were suicidal, homicidal. And I really don't want to stir up the hornet's nest. I don't want to take them off their medication. So they end up not taking them off their medication, or not. That's a bad choice of words. They end up not decreasing their medications for fear of what might happen. Okay. And that's truly clinical judgment. Okay. I'm not faulting any health professional for doing that at all. I'm just telling you what the fundamentals that we're taught tell us to do. And I firmly believe it's the human thing to do. We owe it to people to try to reduce their medications. Here's the problem with it. When we reduce medications, if we have not addressed the root cause, we're probably going to have the same problem again. Okay. So I understand the fear. I really do. If you don't understand what we understand on the functional medicine side, then I get it. I get that if you don't have the root cause answer, which is fundamental number 1, is seeing if there's another cause for this condition, then I understand being afraid. I get it. So that's why a lot of people end up on medications, because fundamental number 1 was never done. We never found a root cause. And sometimes there's not, okay? Sometimes there's no root cause other than this is purely a psychiatric condition, but it's really obvious when it's a purely psychiatric condition. Trust me on that. So what if there was a way to get ahead of the curve? What if there was a way to acknowledge the early warning signs of a moody brain and take away the power of those early symptoms, those mild symptoms, to keep them from growing worse or growing more severe? There is a way, and there's a way to keep mild issues mild, or maybe even get rid of mild issues altogether. And there's a way to keep mild issues from becoming moderate or severe. And then I have to ask, even if you're already on a medication and you're in that medication hamster wheel, is there a way to address that person? And the answer is yes. So the answer is the same for both of those. If you're on the mild end and you're trying to prevent from going more moderate or severe in your symptoms, and in reality, and I'm just being totally honest, I'm not trying to use a scare tactic, but we're all 1 or 2 life events away from moving from a mild end of the spectrum to a moderate or severe end of the spectrum. It just happens. And it can happen to any of us, especially when we're not properly balanced internally at a cell level, at a cellular level. But the answer is the same for both of these people. Those that are trying to prevent from worsening over time due to circumstances and life events and things like that. And then those that are already in the hamster wheel and want to get out of that hamster wheel, the answer is the same. So I know you're thinking enough already. Tell me what the answer is. Well, it's a holistic approach. Plain and simple. We need to sit down. We need to do a very thorough history. We need to order extensive functional lab work. And this is different than your general do your annual physical type of lab work. This is very extensive lab work. And we need to look at your genes. I firmly believe that we should look at your genes first and let the genes dictate where we go with our laboratory work. Sometimes it's not going to change the laboratory work that we would check from a functional medicine standpoint 1 iota. We stay the course and we would do the same thing. But sometimes you see something in the genetics and you go, huh, I need to check this, this, and this because this showed up in their genetics. And it's really an eye-opening experience. Here's what I found clinically. When you're able to pinpoint those root causes at the gene level, at the genetic level, then we're able to put interventions in place. There's this whole system in your genetic code called the epigenome or epigenetics. It simply means that they are the switches that control whether or not genes get turned on or off. And it's a really cool system. And we can modify those switches so that we can coerce the genes to do what we want them to do. So for instance, if you have bad neurotransmitter genes and they're all flipped in the wrong direction, meaning your bad genes are turned on, your good genes are turned off, we can coerce them with the right lifestyle modifications, right supplementation to turn in the correct position and start bringing about that change where we lay the foundation. So if you're a person that's been on medications and you're trying to get off of them, we've got to lay that foundation first before we challenge coming off of those medications. But once we lay the foundation and we get your body at a cellular level functioning like it's supposed to, and when I say cellular, I point to my chest, but I'm talking about cellular all over in your brain and all of your tissues throughout your body. When we get those tissues very healthy and they're able to function the way they were intended to function, then there's a good possibility that when we start coming down off of antidepressants, we're able to stay off those antidepressants. That's just what I've seen clinically. I've also seen people who were trying to avoid being put on antidepressants in the first place be able to never have to go on medication, period, simply because we got their body balanced. Okay. So that's about it. A holistic approach that involves the whole person from the genetic level and the cellular level all the way up. Okay. And once we understand that, once we have that landscape, that picture of what you look like on the inside at the genetic and the cellular level, then we can develop a plan to kind of say, okay, this is our prevention plan. This is how we're going to overcome this. This is how we're going to move forward. If you're interested in learning more about that, I've created a boot camp called the Gene Hack Boot Camp. It's a 5-day boot camp. And by the end of that 5 days, I promise you'll have a keen understanding of exactly where you need to focus your energy on your wellness journey. You'll learn about the exact genes you need to have tested in order to address any hangups that you might have. And you'll just learn how to become optimized in your brain and your body. Right now, we're running a promotional special, and the boot camp is free. I can't promise you how long it's going to be that way. We're testing it right now. So you're going to get an amazing deal, free 5-day boot camp. It sounds like a lot of work. It's not. We're looking at changing the name because boot camp, the connotation there is, man, that's hard work. It's not hard work. It's really passive. It's learn at your own pace. You can download the lessons at your own pace and work through them. And by the end, you're going to have a keen understanding of what's going on with you and where you need to start. So if you're interested, go to drbriangBrown.com/gene hack/bootcamp to enroll. That's all I've got for today. Tune in next Thursday at noon Eastern Standard Time for our next In the Zone segment, where I'll be sharing, the latest research and my insights about that research as it relates to optimizing your genes, optimizing your mental health, and optimizing your physical health. Most informed, most trusted, and most grateful you spent this time with us today. Until next time, stay in the zone. I'm Dr. Brian Brown.